Abdomen. Can anyone explain what is acute abdomen? We say patient comes to us with acute abdomen. There is a patient with acute abdomen. When you will be in the hospital as an internee or as a resident, you will listen to this statement very often. So, what is an acute abdomen? When you label this patient as having an acute abdomen, any idea?
Acute cholecystitis,
Okay.
acute abdominal pain, like
Yes.
any site of the abdominal pain of the abdominal quadrant.
Okay, so to define acute abdomen, it is actually a clinical presentation and clinical picture of sign and symptoms of abdominal pain and tenderness. And it usually requires emergency surgical therapy of less than 7 days duration. Uh, it is usually the acute abdomen, usually it has a presentation of acute onset and needs some sort of intervention within 48 hours, but sometimes it is extended for 7 days or till the 7 days. So the whole presentation of the patient that is deeming surgical intervention necessary is called acute abdomen. The problems, the multiple problems like acute appendicitis, acute mesenteric adenitis, acute cholecystitis, all different quadrants of the abdomen, they may have some sort of inflammation, some sort of problem that may make the patient suffering from acute pain or tenderness, and that all those all they come under the umbrella of acute abdomen. So we'll discuss this topic with the basic definition and the principles, how we see the patient and how we continue managing it, how to diagnose the patient. Diagnosis is not just investigation starting from your history and examination, how you can differentiate the problems arising in different quadrants and how to make a differential of a set of differentials for that. And then what is the management option for that patient in different in a broad category for different scenarios, and when you take the decision to operate that patient. Okay. Definition, we have already discussed it. So it is usually a silent symptom of any intra-abdominal problem that is causing pain and tenderness. And why we call it acute surgical abdomen, because we usually plan surgery for the treatment. So it needs proper evaluation and management, because you have to plan surgery for that patient. That is a big insult or risk for the abdomen wall itself. So you have to be very careful whether this patient needs it, and if the patient needs it, is it emergent, means you have to operate him at the spot, or is it urgent that you have to operate him within hours, or you can wait. That patient is stable enough, but the problem is still going on. You have to wait for around 1 to 2 days, but usually even in the cases of obstruction we don't go beyond 72 hours. We have to operate within 72 hours. So you have to stratify the patient in which categories it fall. And the best approaches, think about the worst case scenario. What if is very important here. Keep in mind the worst case scenario and manage the patient according to it. Remember the medical causes of abdominal pain also, and after you rule out the surgical causes, you are sure that emergency surgery is not needed. Think about the medical causes of that problem too. Okay. Now, when we take the history of the patient, this is the presentation is abdominal pain. So when you are taking the history of abdominal pain or painful abdomen, the important thing is you know what are the points of pain that you should ask from the patient, and those categorization characterization of the pain actually helps you a lot in the exact diagnosis. You should ask about what are the points that you should ask in the history of pain. You all have been aware of it and you are doing it a lot since you are in level 9. So, can anyone tell how we take the history of pain, how we start, and what are the questions that we ask for
We
the
start
patient?
we start first of all the site of the pain.
Okay.
We ask of the site of the pain. We know Dr. Scratus, the site. When does it start?
Okay.
How does it start? Is it sudden or grating?
Uh,
Also, we ask about relieving and elevating factor. Uh, that's it. Does it disappear or not? That's it. That's it.
Referral radiation relation with the is it as it is abdominal relation with the meals, relation with the position and the movement. So Socrates is a very good mnemonic for it, and you should be aware of it. So first is you will characterize the pain. What is the character of the pain, and what are the other broad specifications of that pain. And there is usually the pain in the abdomen. It is of two types: so visceral pain or the parietal pain. Actually, the visceras, they have autonomic innervations. So usually the pain is not as specified as the pain anywhere else in the body. So if there is problem in the viscera, unless until the visceral peritoneum, parietal peritoneum is inflamed, usually the patient presents with a diffuse pain. So the same, the very simple example is of appendicitis. Initially, when you ask the patient says that I have pain in the central abdominal. Why? Because the viscera was inflamed, and the visceral peritoneum that was covering that viscera, only it was being stimulated, and the brain was taking it as a problem that is related to the midgut, and patient patient says that I have pain in the central abdominal. He cannot localize it, I have pain here or there. He just says that I have pain in the central abdominal, and it is dull, it is vague pain, it is not sharp. But when the inflammation continues, the inflammation spreads from the visceral peritoneum to the parietal peritoneum that is covering that viscera, that is over that viscera, over the appendix. Now, when the parietal peritoneum is affected, it is being innervated by the somatic nervous system. And now the patient starts complaining that I have pain in that specific point, because now the somatic nerves, they are being stimulated, and the brain localizes, yes, this is the pain point, this is the point where it's a pain. So visceral pain and parietal pains, they are different, and this is because of the nervous system that is involved there. And usually the visceral pain is dull, it is not localized, poorly localized. The whole area of that part of the gut is felt as having problem. And patient has the patient has other vague symptoms also, like distension, and some symptoms of bloating, and some having some gas problem inside. The patient says vague symptoms. But when the parietal peritoneum is affected, the pain becomes sharp, the pain become better localized, and you have other specific signs for the specific viscera involvement also. So you have to take careful history of the pain to find out the problem. Then if you know which area, the first question he said is site of the pain. It is very important, because your differential list depends on the site of that problem. And then when you have that specific list of differential in your mind, you are directing your questions to find out the answer of those differential, which differential is fitting in this patient. So if you're having a patient presenting to you with epigastric region problem, patient says I have pain in the epigastric region. Think about the problems of the organs that are inside. We have the stomach there. We have with the stomach the part of the duodenum. We have some part of the pancreas there. We have some loops of the gut in that area. So your differentials are according to that. Like you can see in this picture, we have problems related to the stomach, like peptic ulcer disease or gastritis, or pancreatitis, duodenitis, gastroenteritis, early appendicitis, mesenteric adenitis, mesenteric thrombosis also can also present as pain in the epigastric region. Then on the sides, you have hepatobiliary system involvement on the right side. So, and even sometimes the splenic flexure and hepatic flexure are there, so that can also be presenting as pain in the upper abdominal region. And then the umbilical or the central abdominal region. Here we have, if we talk about only the midgut, this is the area where the midgut is present and the patient has pain in this area secondary to midgut inflammation. So it could be appendicitis, it could be gastroenteritis, it could be some part of the cecum and ascending, some part of the ascending colon, or ascending colon and some part of the transverse colon. You may have mesenteric adenitis and mesenteric thrombosis and symptoms of, or sorry, pain of intestinal obstruction in this area. And then we have the lower abdomen, that is the site of the uh, radiation of the, or sorry, site of the dermatomes of the hindgut. So we have problems related to the gut second after the transverse colon, after the first third of the transverse colon till the rectum and the anal canal. Then we have the other viscera that are present there. We have the bladder there, we have the entry of the ureters there, we have in the females there are the female genital tract problem related to the ovaries, the problem related to the uterus. They all present as pain in the lower abdominal region or the hypogastric region. So when you are having a patient presenting to you with acute abdomen, localize the site and then make a differential in your mind that it could be this, this, this. And then when you are asking about the detail of that pain, ask for specific questions regarding that pain, as well as ask associated questions about these differentials. Like if you're having a patient with peptic ulcer disease, you're suspecting peptic ulcer, you will ask questions about peptic ulcer problem, the relation of the pain with the meals, and the patient's habits of taking any painkillers or some steroids, etc. You will ask questions to manage, sorry, to reach a specific provisional diagnosis with your history. This was about the vague pains that is usually visceral. Now the parietal pain. Now parietal pain is specific. We discussed some before also, but now specific quadrant pain and specific organ pain. Gallbladder pain, right upper quadrant. A pain to the sorry, appendicitis pain in the right iliac fossa. Problem related to the ureter and the bladder, they are usually in the hypogastric region. The problems related to the sigmoid and the rectum are usually in the left iliac fossa. So different presentation will have the symptomatology in specific quadrant where that viscera is present. Okay. There is another term that is called referred pain. Can anyone tell what is the difference between the referred pain and radiation of the pain? What is the difference between a radiation and a reference, or referring of the pain, or referral of the pain? Any idea? Okay, these two terms, they are sometimes they are.
Ben,
Yes.
Ben, go to other site.
What is it?
Like biliary disease to the shoulder
Okay.
side.
What is the difference between referred pain and what is the difference between
Radiate, continue pain with.
Yes, radiation means the pain will be in the initial viscera as well as radiating to some other area. But referred means sometime you will have only the referred area pain. You will not have the pain in the area of the involvement of that that viscera is not causing pain and in that specific position, but you will have the pain referred to the area where and the dermatomes are supplying to the skin. This is called referred pain, and a very typical example of it. These are actually sometimes these are overlapped. The patient is having sometime radiation as well as referred pain too, but there are some specific cases which are the exact example of referred pain. One of the example is the splenic injury pain. Patients having splenic injury, they usually present with hematoma or a blood collection in the abdomen. And when we say the patient, when we elevate the foot end of the patient, that blood touches the diaphragm, and patients who is not complaining anything in the in the left hypochondriac region, now he starts complaining of pain in the left shoulder. So this is a very typical example of referred pain. And sometimes we still call it referred pain even if there is pain in the abdomen also, because the pain is generalized. It is not localized to the right leg for left hypochondria. Okay, so referred pain is when you have a pain referred to some other site, and the area of injury or the area where the problem is usually asymptomatic. The example that is shown here, they are of the biliary disease. Like in biliary disease, patient says on the same side of the back or on the tip of the shoulder blade, patient says that I'm feeling pain. And even if we examine it, there is hypersensitivity also in that area, and it's a specific sign for biliary disease, even if patient is not saying any problem, but that area is hypersensitive. Then in left diaphragmatic abscess, a patient may present to you with pain in the left shoulder. That is Kehr sign, which is a diagnostic for splenic injury or hematoma of the spleen, or bleeding from the splenic laceration. Then above the diaphragm, problem which are above the diaphragm in the lung area, usually they have referred pain in the neck or the shoulder region. And if it is acute onset and it is not settling, this is a bad sign too. So keep this thing in mind, that the pains which usually resolves are not acutely surgical, means they do not require any acute surgical intervention or immediate surgical intervention. Okay, the history doesn't end with the pain itself. You have to take detailed history of that viscera, of that specific quadrant organs. You have to ask about other GI symptoms like nausea and emesis or vomiting. And if the patient is vomiting, confirm the nature and amount of vomiting too. Is it bilious or bloody, or what is the amount of that amount and the status of that vomitus. Then constipation and obstipation. What is the difference between constipation and obstipation? What is obstipation?
Constipation is air inside the stomach with feces.
Air inside the
accumulation of excessive gases inside the abdomen. This is the obstipation, but the constipation is difficulty in passing the feces.
Okay. If you have time, you can go through the exact definition of constipation. Even it is passage of hard stool, and we vaguely it is also included in it. But if the patient is unable to pass stools for 3 days, usually it is taken as a chronic constipation. Okay. So when you are asking about history of it, you have to ask about the last bowel movement. If the patient is saying that I haven't passed stool for many days, ask about when was the last bowel movement and when was the last time he passed flatus. And then if the patient is having diarrhea, ask about the nature of the diarrhea, amount, frequency, color, any abnormal thing in it, mucus or any other discharge, blood. take in detail about those symptoms. Then relationship with the eating. What are the change in the pattern of eating? Is he having any loss of appetite, or if he's this pain is related to some specific site of specific type of eating, like in patients with peptic ulcer disease, uh, there is a relationship of the pain with the meal intake. In gastric, patient eats and develops pain, so these patients, they don't like to eat. But in patients with duodenal ulcer, they like to eat, because when they eat, their burning sensation or the pain, it settles. So you have to ask about the relationship between the eating and the symptoms. And in patients of um, gallbladder disease, patient says that I feel more pain when I eat fatty meals like fries or fried things. So you have to ask the relationship of that pain with the eating too. Then uses of some medications like steroids and NSAIDs, they are also prone to cause pain in the specific region, in the epigastric region, and it is a very common cause of perabdominal pain in old age patients who are having chronic arthritis or chronic joint pains. Then other histories that you should ask about are the jaundice. And if patient is jaundiced, ask about the stool and the change in the color, because it is uh, uh, a surgical cause of jaundice, or we call it the surgical jaundice, cholestatic jaundice, which needs surgery to be as a cure. So if patient is having jaundice, rule out the surgical jaundice too. Okay, drinking history is important, because pancreatitis pain is very much related to the intake of the alcohol. And if the patient is having prior surgeries, like maybe operated for appendicectomy years back, but if the patient is having such history, think about adhesions as the cause of this abdominal pain. When thinking of acute abdomen, thinking intestinal obstruction as the cause, take history of hernias too, because previous hernias in the abdomen or the abdominal wall, that although present for years, but they may sometime become irreducible and stuck, and patient may develop sudden obstruction symptoms. Then ask about the patient's urinary status, patient is passing urine or not, because all these conditions of acute abdomen, they may cause, especially the bowel obstruction, they may cause dehydration, and patient may have a low urine output for previous few hours or previous few days. Ask about the constitutional symptoms like fever, chills, anorexia, and other common symptoms, and weight loss if it is present for long. Like in a patient with a chronic condition, superimposed, an acute condition superimposed on a chronic condition can have constitutional symptoms of weight loss too. Then ask about the sexual and the menstrual history too, in cases of in case of female patients. Okay. So whenever you are taking history, think about the broad classification of the surgical causes of acute abdomen: inflammation, obstruction, ischemia, perforation. These are the four broad categories. And out of these, the most problematic things for us are the perforation and the ischemia. The rest two are also problematic, but they give us time to for management. But in case of perforation and ischemia, we have to be very vigilant, and immediate action is needed in these two categories. So in perforation, any of the above, the inflammation, obstruction, ischemia, any of these can end in perforation. And the problem is it is a stepwise, you can say, end of a story. Perforation is the end of a continued story. Initially, there is inflammation that organ which is inflamed, it can become obstructed. And when the obstruction is too much, the blood supply of that specific segment may be blocked and undergoes ischemia, and later on that ischemic segment may perforate. So perforation by step wise pattern can be the end of any of these three things. And the offended organ, it becomes the standard. There is generalized abdominal distension, and if it is if you see the temperature of that region or that specific area, the temperature is raised, showing you all the signs of perforation, and starting from the inflammation, showing you all the signs that are present there. And if you are having these signs, keep it in mind that you may have to intervene immediate. Okay. How we can differentiate a problem is just an inflammation, or a problem is just an obstruction, or problem is obstruction. It is because of the presentation. A patient having inflammation, usually the problem is and the symptoms, they are not having a mechanical obstruction, and the pain nature is changed. The pain in the inflammation is dull, vague, it is not localized. But in case of obstruction, the patient usually presents with colicky pain, because it is causing that viscera to be obstructed. The patient will have very severe colicky pain, and the pain is depending on the involvement of the parietal peritoneum over it. Pain may be very sharp and localized sometime. Okay, so if we see the detail of the organs one by one. In the stomach, usually the problems that we have are the gastric ulcer and the duodenal ulcer, and they may perforate, and they have their specific presentation of perforated peptic ulcer disease. In biliary tract, we may have acute cholecystitis, acute cholelithiasis, and choledocholithiasis, and in severe cases we may have biliary obstruction secondary to the stone passing in from the gallbladder into the duodenum, and then going on to cause obstruction in the ileum. Then we have pancreas, in which the problems can be acute or current, acute or recurrent chronic pancreatitis. And in small bowel, we have Crohn's disease or Meckel's diverticulitis. And in large intestine, we have appendicitis and diverticulitis. And on the other hand, if we talk about the obstruction problems, the small bowel obstruction problems can be the adhesions, they can be the Band's problem or the bulges, they can be the malignancies or inflammatory bowel disease. In the large bowel obstruction, the problems that we have in the large bowel, they are mostly because of the malignancies of the sigmoid origin, or the colonic or rectal origin. These could be volvulus of the cecum or the sigmoid, or this could be diverticulitis. So you have to think about, first you identify whether it is an inflammation and obstruction, and then identify the part of the gut that is involved in that obstruction. Now, for ischemia and perforation, it is usually presenting as a dynamic obstruction. We will discuss it in the next lecture. An adynamic obstruction is an obstruction in which there is no active movement of the gut. There is a gut movement, but that is non-propulsive. It is not causing the stool to move forward. And it is because usually because of the obstruction of the vessels, usually the superior mesenteric artery is occluded here, and that occlusion can be because of thrombus or embolism. And mesenteric ischemia, the typical history is of old aged people with having any cardiac event, or who are already having some cardiac problem, and or they may have severe atherosclerotic vessel disease generally. And the general peripheries, they have atherosclerotic problems. Then we have ischemic colitis. Then we have chronic mesenteric ischemia. Again, these are the patient presenting with smoker. Vasculopathies are already there with severe atherosclerotic disease. And why we call it chronic? Because the symptoms are not as acute. The patient is having a prolonged history, and there is a recurrent attack of mesenteric ischemia. Then we have ischemic colitis, or we have any inflammation, obstruction, or ischemic process which can affect the gut, and ultimately it will lead to perforation. And one more problem of the gut that may present with perforation is the ruptured abdominal aortic aneurysm. That is another entity that you will cover in the vascular lectures. I'm not going into the discussion of this. Ruptured abdominal aortic aneurysm is also presents as an acute abdomen sometimes because of the sudden rupture, and sometimes this aortic aneurysm, it may form fistulas with the gut over it, and you may have aortocolic fistula that may present with bleeding PR and other symptoms. So an abdominal aortic aneurysm can present as an acute abdomen, or it can present as a surgical emergency. Okay, then gynecological etiologies could be problems related to ovaries, problems related to the fallopian tube or the uterus. We have discussed thing before, or with level 10, I think, winter tumors or the mid-cyclical pain, and even ovarian cysts, they may present as right leg fossa pain. Then ectopic pregnancy, sometimes ectopic pregnancy can be the cause of sudden onset acute abdomen, and with unstable vitals. Usually patient presents like this in the emergency. And just asking about the last menstrual period, and the what do you say, examination of the genital region can differentiate ectopic pregnancy from normal surgical acute abdomens. And in uterine causes, could be uterine rupture or endometritis. They also present as acute abdomen. So any patient presenting to you with sudden severe abdominal pain, go for simple blood test as well as tests for to diagnose the problem. A CBC with differentials, when we go for a complete blood count, and we see left shift in it. Left shift means that young neutrophils are more in that specific. There is neutrophilia. Neutrophils are more, but banded neutrophils with the bands, they are the young formed neutrophils. So when there are more neutrophils with bands, it is an indication that this patient is having a neutrophilia with even if the neutrophils are within the range, that new neutrophils with the band formation in abundance, that gives you an indication that this is a left shift of neutrophils. Then you can go for electrolytes. You have to go for go for the LFTs and the RFTs. For the specific identification of the pancreatitis, go for amylase or lipase. And after seeing the patient, if you're suspecting that this female patient may have ectopic pregnancy or problem related to the gynecological disease, go for a beta HCG level. Beta HCG is usually high in ectopic pregnancy. Imaging studies, the X-rays are very important as they differentiate bowel obstruction or free air under the diaphragm. And ultrasound is also very important, as it is the best diagnostic modality for hepatobiliary problems or gynecological pathologies. And you can say the last of all, CT scan is the best investigation, the diagnostic accuracy. But we don't do it in all the cases. It is done in the cases in which all these above things, they are not leading us to a specific diagnosis. Okay. A 19 years old man with periumbilical pain that shifted to the right lower quadrant, and he was febrile sick with a tender right lower quadrant and underwent a CT scan. What you can see here in the CT scan is there is an inflamed organ that is most likely between the cecum and this is the start of the cecum, so it is most likely appendix. But if you can see, there is some diffusion in the periphery, so there is pericholecystic fluid or periappendiceal fluid, or that can be one of the indication that it may have perforated because the patient is febrile and sick. So usually we don't do CT scan in acute appendicitis, but if your diagnosis is plus minus and the patient is having severe symptoms, and you can offer a CT scan in the patient. Okay, now in which cases we have to go for an emergency operation? These cases can be peritonitis. If the patient is having localized or generalized peritonitis, there is tenderness with rebound tenderness, or there is involuntary guarding. What is the term we use for involuntary guarding? What is involuntary guarding? What is guarding and what is involuntary guarding? You have done abdominal examination. We use the term guarding in abdominal examination. Now tell me, what is guarding, and is guarding voluntary or involuntary? Any idea?
Can you repeat the question, please?
What is guarding?
Muscular response.
Mm-hmm. To
The spasm.
To what?
Because due inflammation.
If there is underlying inflammation,
Yeah.
and you try to palpate that area voluntarily, this is voluntarily. Voluntarily is important. Patient is voluntarily making his muscle, abdominal wall muscles tense or contracted in that area. This is called guarding. When you are palpating the other area, the abdomen is relaxed. But when you palpate the area where there is pain, usually you see sudden stretch of the sudden contraction of the muscles over it, as if the patient has guarded his muscle to stop you from palpation. So this is called guarding. This is called guarding. But what is involuntary guarding? The term we use for involuntary guarding is rigidity. What is rigidity? Without any voluntary effort, the abdomen is rigid. It is board-like, especially in cases of perforation. The abdomen of the patient is described as board-like. It is like a board. Patient is not doing it voluntarily, but there is what you say, there is involuntarily all the muscles of the anti-abdominal wall, they are contracted. I remember one patient while I was in during my training years, a young man about 30 years. He presented with mild pain. He didn't say that I have severe pain. He said that I have mild pain in the epigastric region, and that pain was for like 5-6 hours. And that patient was actually a laborer, and he was used to smoke a lot. He didn't appear to be in too much distress, but he said, I'm having pain, I don't want to get up. And when I palpated his abdomen, what he was saying was like, there is not anything to worry. But what was his abdomen? It was like a table. It was not letting me palpate anything. The abdomen was very tense. And as the patient was apparently not in a state that we were to take him to the emergency operation theater. So we planned, okay, we will go for an X-ray. We asked him to go for an erect extra abdomen, and what we saw when he came back, there was an air under the diaphragm. That patient, he was a laborer. He was, they are very hardworking people who are the laborer. So he was having so much stamina that he was bearing all the pain, whatever it was, and he was not thinking it to be much because he had to go back to his work. But he actually had a perforated peptic ulcer, which initially presented as a perforation, and then it was sealed by the omentum. So when the omentum sealed it, there was no further discharge from that perforation. Still, the patient had peritonitis that involuntarily had caused all the abdominal wall musculature to become tight. So this patient had peritonitis, but just by the history of the patient, we were not getting any point. Only thing was positive in his history was smoking. So sometimes you have to be, that's why we said in the very beginning, think of the worst case scenario. If you are thinking it is a board-like abdomen, keep it in mind that it is something fishy. It is peritonitis. And then another call or indication for emergency surgery is the patient is hemodynamically unstable, patient is tachycardic, patient is losing blood pressure, or if the patient is having septic features like white blood cell count is too much high. Then in cases of intestinal ischemia secondary to obstruction, strangulation, or closed loop obstruction, and in cases of pneumoperitoneum, there is air in the peritoneum, or if there is complete or high grade obstruction, and it's not relieving with the, or not getting better with the passage of time, go for surgical repair. Okay, sometimes there are some situations that make diagnosis difficult, like in patients with multiple injuries or patients with multiple chronic problems, patients with a stroke or spinal cord injuries, patients who are under the effect of illicit drugs. And sometimes the severity of the disease can be masked by a certain medications that the patient is already using, like steroids, immunosuppressive agents, and threshold to operate these patients must be even lower, because the things are masked. Usually the severity of the disease is masked by these medications. And so the take home points for from this lecture is: take a careful history, the problem related to the specific quadrant, and the history of the presentation. So what is the presenting symptom? Take a careful history of that, and keep the differentials in your mind before you are taking history, because you have to fit your differentials, any of the differential in the provisional title. So you have to take a careful history to narrow down your differential, and then we take the assistance of the examinations and the investigations. Acute abdomen is an acute emergency, so always perform ABCs and resuscitate the patient before start doing investigations, or start taking long history to evaluate all the things. First, resuscitate him. If the patient is having severe pain, try to make the patient NPO, try to give him fluids, try to give him painkiller before you start ruling out the differentials. And especially don't forget gynecological or the medical causes of acute abdomen, because these could be the reason behind the patient's presentation. Okay, anything from this question, from this lecture? Any questions, sorry, from this lecture? If no, I will start the other one. Any question?
Thank you, Doctor.
Okay.